Good morning, folks. My name is Michael Weinberg. I'm a Senior Research Fellow in the California program of the New America Foundation. And I just wanted to extend my thanks first to all of you for making it to this room. It felt a bit like, this is my first time here, it felt a bit like an orienteering project to surmount the highest peak. But you all made it here, and I think in a couple hours the air conditioning will begin. But a lot of familiar faces out there. So I also wanted to thank a number of people, including Council President Eric Garcetti, who is sponsoring us to be able to use this space, the Blue Shield of California Foundation, who is supporting the work that we do on improving quality and value of medical care in California, and our partners for this event, who did not realize that they were going to be pressed into carrying chairs up through the elevator. But I'm very, very thankful to them and everybody else who helped out with that. The Integrated Healthcare Association and the Headington Media Group that helped us do outreach for this event. I'd also like to thank our panelists. This is the sort of event that I'm actually excited to attend because we have such a terrific group here. And they are Tom Prisolak, who is the Chief Executive Officer of the Cedars-Sinai Health System, Dr. William Chin, who is the Executive Medical Director of Healthcare Partners, and Castelo de la Rocha, who is the President and CEO of Ultimate Health Services Corporation. These are Los Angeles healthcare rock stars, and so it's true. And I am very excited to hear from them. But the truth is that, I mean, looking out into this audience, I feel like I know about at least half of you. And this really is one of those situations where any three people from the audience would make a terrific panel on these issues. So I really appreciate your coming. And one of the things that we want to do at this event is make sure that there's plenty of time for audience interaction. So we'll be asking a few questions at the outset, and then we'll leave plenty of time for questions from the audience. So thank you again for being able to make it here. The structure of the event is as follows. We're going to open with some remarks from my colleague Lee Wellington-Hazy, who runs the California program for the New America Foundation. And he is going to be giving an overview of the relevant provisions of the Affordable Care Act. And then we're going to move on to the moderated conversation portion of the event. So without further ado, Lee.
Thank you so much, Mike. And as many of you know, Dr. Kavita Patel, who directs our healthcare program in DC, was supposed to join us today. She was in South Africa vacationing and seeing the World Cup, and her flight was canceled a few days ago. The number of folks and revelers in South Africa trying to leave her so great that she is actually in the air from Johannesburg, and misses seeing all of you, but will be here in the very near future. I can't think of very many more appropriate places to hold an alternative town hall than at City Hall. And on behalf of New America, I want to thank again Councilman Eric Garcetti for making this space available, and for all of you to come out early on Monday morning to talk about the implementation of health reform and the challenge and promise of implementing it in California. And I should say, before we go any further, and maybe to preempt a couple of questions period, that Obamacare is a convenient shorthand rather than a genetic description of the bill or anything else. After health reform passed this March, the writer in his position, Atul Gawande, rightly pointed out that the supposed federal takeover of healthcare actually depended, for it to work, on states, physicians, and local medical groups and communities. And we've seen, even in states where the Attorney General is challenging the provisions of the Act, communities of policymakers and health professionals on the front lines coming together in full view or in stealth to figure out how the provisions of this bill will be enacted in their states. And it seems very slowly that trends of public opinion seem to be moving in favor of the legislation. And all in all, the climate, I think, is quite markedly different than it was a year ago at this time. And many of us in the health policy community think back to when Medicare was enacted. I'm not old enough to remember that, but you recall that it was an enormous challenge to implement especially in the South, and I think this current climate has a lot of parallels. The heart of reform, to be sure, is the expansion of insurance coverage. Reform is projected to reduce the numbers of uninsured in California from about 6.5 million or more today to roughly 1.7 million in 2019. And in California, in the early days, especially in Sacramento, this is what's being stressed, as in other states that are scrambling to do the early things to reform. Roughly $761 million is going to flow to the state to set up high-risk pools for those with pre-existing conditions. The governance of exchanges will have to be in place by 2014, and as all of you know, there are bills in Sacramento that are thinking about that governance, how to pay for Medi-Cal both now and in the future, and very much of interest to many of you in the room, how the renewal of the federal waiver scheduled for August might help in that very important process. But the efforts to create more organized and coordinated ways to deliver care with the aim of bringing down costs and creating more value both for payers and for patients are as critical to this law as the landmark expansions of health insurance coverage. If insurance coverage is the heart of reform, if we can extend that metaphor, the delivery system reform are the brains, and that is the subject of our panel discussion today. We're going to look at specific on-the-ground efforts in California by healthcare stakeholders to capitalize on the opportunities of federal reform and to adapt its provisions. And as Micah said, to do this, we're extremely fortunate to have with us representatives of the largest, most influential and innovative hospitals, clinics, and medical groups in Southern California, especially in a period of tight state budgets and social needs that include and go beyond health services. Getting the maximum value for each dollar of healthcare spending is both an economic and a moral imperative. And in making real headway on this elusive goal of reining in health costs and getting better value for each dollar of spending was the goal of the California Task Force on Affordable Care, led by New America and sponsored by the Blue Shield of California Foundation, which met over the past year and released its final report in May. Most of you have this on your chairs, and there's some extra copies in the back. And many of the folks in the room and on the panel participated in this and recommended an unusually wide range of reforms, ranging from payment reforms to changes in social behavior. So I really encourage you to take a look at that, because that fits right into the themes of this conference. So what does the Affordable Care Act actually prescribe in the area of delivery reform? And the question we're focusing on today, are these provisions likely to be steps in the right direction, productive or counterproductive, sufficient or insufficient? And I'm going to kick off the conversation by briefly flagging just a few key elements of the bill that relate to the way healthcare reform affects patient care. Efforts to shore up primary care and encourage the creation of so-called medical homes, the implementation of new payment methods that move away from paying separately for each episode of care, and a test of organizations that would put physicians and hospitals and other entities in charge of and at risk for providing timely care of high quality to so-called accountable care organizations, or ACOs. So to take each of those three things briefly in turn. Primary care. Across a wide spectrum within both the physician and policy community, the consensus has grown that the declining coverage and reach of primary care, family medicine, internal medicine, and pediatrics, has been counterproductive, that it generates higher costs and worsens the patient's experience. And as primary care has waned, the coordination and continuity of care have suffered. Only 2/3 of U.S. adults under the age of 65 report having access to a primary care provider, and nearly 3/4 say they would have a problem seeing a doctor if they're sick. And only 1 out of 14 medical students now say that they're going to pursue primary care as a career. Roughly half of all California primary care physicians are over the age of 60. And there are only 3 areas in California, Orange County, Bay Area, and Sacramento, where the number of primary care doctors is deemed to be sufficient. And as you all know, expansion of care to the uninsured is likely to widen this gap between the demand for primary care and the supply of physicians. So the Affordable Care Act takes a number of important steps in this area. It changes the allocation of graduate medical education slots to encourage primary care, makes new funding available for community health workers, increases reimbursement for primary care doctors under some circumstances, includes incentives for expanding provider supply and a more diverse workforce in underserved areas. The legislation also supports and plants the seeds for it through a Medicaid state option for patients with multiple chronic conditions. The actually older idea of a medical or health home through which a patient will receive accessible, coordinated, and integrated care. And I think we've got some folks in the room who are working on this, but the implementation plan for the new federal Medi-Cal waiver builds on the successful coverage initiatives in 10 counties and takes significant steps in promoting the medical home and coordination of care concept. One of the biggest unanswered challenges both for public hospitals and for states is how the existing safety net of coverage, which serves the uninsured and undocumented immigrants, among others, will fare in the wake of federal reform. Federal dollars which used to go to hospitals and states to care for the uninsured will be moved to help underwrite the cost of coverage expansion and to pay for patients in new settings such as community clinics. It's projected that the roughly 1,100 federally funded community health centers in California will receive about an extra $1.4 billion over 5 years, the state share of the roughly tripling of funds nationally toward this end. And we're going to hear from Castillo de la Rocha later about the details of this. Secondly, reimbursement and payment reform. In many, many ways, the intent of the health reform law is to pay hospitals for the health outcomes of patients rather than for discrete episodes of care, reflecting what George Halverson famously said of Kaiser Permanente, said about reimbursements and payments. There's no code for health. And most of these changes are being driven through changes to Medicare reimbursement policies, which are also responsible, of course, for paying for part of the cost of the reforms themselves. Coverage expansions paid for in part by hospitals accepting slower growth of Medicare payments and payments for uncompensated care. Coverage expansion is expected to yield about $40 billion in revenues to hospitals, according to the Urban Institute, but $20 billion in lower payments are expected by 2019. So what are some of these payment reforms? Rules about hospital readmissions and payment are being significantly toughened. According to the Agency for Healthcare Research and Quality, over a 2-year period, roughly 1/4 of all hospital patients and 40% of Medicare patients were readmitted for the same conditions that caused their initial hospitalization. So in response to that, starting in 2013, Medicare payments will be reduced for hospitals with high rates of potentially preventable readmissions in the areas of heart attacks, heart failure, and pneumonia. And the Secretary of HHS is going to make the information on hospital readmission rates public. And Medicare will continue to deny payment for treatments associated with hospital-acquired infections, and that's going to be extended to Medicare as well. In the work we did with the California Task Force on Affordable Care, we estimated that the state can save $35 billion over 10 years by reducing these preventable hospital readmissions and healthcare-associated infections. A few other key changes. Hospitals that meet benchmark standards for pneumonia care, heart attack care, and heart failure and preventing surgical infections will be eligible for bonus payments from Medicare. There's going to be an independent payment advisory board starting in 2014 that will recommend policies to reduce Medicare spending in any year in which the growth of this spending exceeds a target rate, although it should be said that hospitals will be exempt from that from the provisions until 2019. And perhaps most interestingly, the concept of bundled payments is being explored through both the Medicaid demonstration project and a Medicare pilot. Bundled payments, as you all know, are an alternative to fee-for-service payments, in which a single payment is made for all services related to a treatment or condition, presumably spanning multiple providers in many settings. The thinking among analysts is that such payments will be especially useful for treatment complications that arise from chronic conditions, which many studies estimate are responsible for as much as 60 to 70% of healthcare costs. And obviously, bundling payments, as most of you know, raise big and potentially intractable questions such as who controls the bundle and how do you set the overall level of reimbursement. But the broader question here is whether all of these many nudges in the law will convince hospitals and doctors that it's really the end of business as usual and that the dominance of a fee-for-service, episode-based system of payment is at hand and that this will prompt a more holistic wholesale reorganization of how healthcare is delivered. And that brings me to my final snapshot. Federal legislation, along with many policy experts, including some here, have urged the creation of accountable care organizations, provider-led organizations that would be responsible for the overall costs and quality of care for a defined population of patients. These groups of providers, which could include hospitals, would be legally constituted to receive and distribute payments to other providers, to invest in redesign of care and infrastructure, for instance, electronic health records, to coordinate care, and to reward improvements in quality or efficiency. In the law, the ACOs are encouraged through Medicare pilot, begins in 2013 and could be expanded subsequently, and a Medicaid pilot that allows pediatric physicians serving Medicaid patients to organize ACOs. And ACOs, to me, have a strong resemblance to the earlier and still ongoing concept of managed care, except that medical providers, rather than insurers, are in the driver's seat. Whether and how these entities will happen is certainly a matter of debate. I was at a healthcare conference the other day with a very nationally prominent healthcare expert talking about ACOs, put up a slide of a unicorn and said, you know, everybody recognizes this as a unicorn, but have you ever seen one actually walking, or either in captivity or in the wild? And I would actually use that as a foil to the ACO concept, because we have the components in California: integrated delivery systems, multi-specialty group practices, physician hospital organizations, and independent practice associations, which, with this sort of knowledge and experience with capitated payments combined, should be the kernel of the accountable care movement, and we'll hear a lot more about that today. It's interesting and a little ironic that California has been historically home to these kind of managed care organizations and integrated systems, to which this law gives a leg up. But there's some evidence that this model of delegated and capitated care is eroding in the marketplace, even as it gets its moment in the sun in national reform. And I'll conclude by saying that to make good on the healthcare, the federal healthcare promise, it actually goes a little bit beyond implementation. In some ways, many of the folks who are represented here today, both on the policy and practitioner side, need to take ownership of these particular openings that are in the federal law. And I believe we're seeing a lot of that happening, and I think we're going to hear a great deal about it today. In the area of healthcare, as in many other areas, California has many of the biggest obstacles to reform and many of the greatest strengths. As the philosopher Josiah Royce once put it, the depths of California's failings are matched only by the degree of her incomparable strengths. So on that note, I'll turn it over to Ken.
So about a little over a couple of years ago, my wife and I had our first child. And I don't know how many of you folks have gone through this experience, but all the focus is on the labor and delivery. Right? How's it going to go? Where are we going to do it? How's it going to turn out? And then you go and you do it, and it turns out however it does. And then they give you this child to take home. And maybe you've read a little bit of stuff, and obviously you were raised, but at least for my wife and I, we had not focused nearly as much on what to do with the child as we were focused on, how's this all going to, get started. And when I think about federal healthcare reform, I think that's kind of how the process went last year. The question was, is it going to pass? Is it not going to pass? What do we have to do to make it pass? Are we going to win? Are we going to fail? How's this going to happen? And then we passed federal reform, and I think a lot of people want to just move on. Right? But as with raising a child, that's actually the most important part of doing something significant of this magnitude. And so today's event and our task moving forward is not fundamentally to look back at what we did, but to look forward at what we have yet to do. Because federal healthcare reform, it doesn't exist. There is no sort of definitive set of rules that will completely determine how it is that we're going to be providing medical care and health insurance in the state going forward. Federal health care reform is a process, and this process could lead to a number of different outcomes, particularly on a state-by-state level. So for this event, we've called together really some of the best experts, both yourselves and the members of the panel, to talk about this process, to metaphorically and actually, because of the temperature of the room, literally roll up our sleeves and focus on the fact that the political games are over, and now the real work begins. And so the first thing that I wanted to pose to the panelists today was what my colleague Kazi called the heart of healthcare reform, but I want to ground it in the experience of the patients. To as great extent possible, I don't want to focus on the billions, right? I go to a lot of talks, and there's a lot of hand-raising in Sacramento about how many billions of dollars are we going to get from the federal government? How many hundreds of millions of dollars are going to fund this particular program? And we'll talk about some of that. But for the most part, I want to talk about what people actually want to know, which is to say, how is this going to change the experience of a person seeking new insurance, a person entering a doctor's office, entering a hospital? How is this actually going to affect them? Will they notice that we passed federal health care reform? Why or why not? And what do we have to do going forward to make sure that they get the best quality care at the most affordable price? So I want to pose to the panel, starting with you, Costello. So there were increased funding for community clinics. And the question is how is this going to influence the experience of people in Los Angeles? Will this make it easier for them to access medical providers and medical care?
Well, thank you very much for giving me the opportunity of being here for part of this panel this morning. I haven't been called Hollywood star recently, so thank you all very much for that acknowledgement.
Do you want to use the microphone?
Oh, I'm sorry.
Sure. Well, we've got mics that are getting past. So.
For 33 years, I, along with a number of people sitting in this room, have been working for something called healthcare reform. I am delighted, pleased at the opportunity of being part of that process, and being part of that process for 33 years. We are a federally qualified community health center. Our primary focus over the years has been working with Latino populations. As you well know, the largest number of people that are uninsured in America today are Latinos, regardless of where you live, what state, what county, what municipality. The largest concentrations of uninsured population happens to be the Latino population. They also happen to be concentrated in small, I shouldn't say, but poor communities, working poor communities. What's interesting is that 37 million people would now be insured. The state of California, about 8 million people are uninsured. We know that this is going to close the gap in providing access to populations that traditionally have not had access to it. And I am absolutely delighted at the prospect that organizations like our own that have set their roots in those communities, the working poor communities, the uninsured and underinsured communities, will now have an opportunity to open up their doors to a much larger group of people that would have access to it. Big challenges for us, of course, continue to be access to physicians, to nurses, and to the staff that would be needed to manage the increased numbers. As we think about healthcare reform, while that delights me, the prospects of bringing additional people into our systems, what bothers me is that despite the fact that somewhere in the neighborhood between 5 to 6 million people in the state of California would be insured through the exchange or through Medicaid, there's still another 2 to 3 million people, and heaven knows between now and the year 2014, whether that number would be larger, that would remain uninsured. So the pool on resources, dollars, as well as personnel, and people needed to care for that may give us a greater challenge in the future of continuing to care for that large uninsured population in the future.
Excellent, thank you so much. Dr. Chin, I want to move to the issue of how the coverage expansion is going to influence the people that are either currently with healthcare partners or maybe joining, and perhaps even especially that there is a huge Medicaid expansion as a part of federal healthcare reform, and therefore that some of your doctors may or may not be bringing in new Medi-Cal patients. So how is the coverage expansion going to influence the experiences of the folks who are members of your organization?
When we look at healthcare reform bill today, our focus has been on the accountable care organization rather than specifically the payment model. We believe that the accountable care organization offers a intervention where we can improve the care for our patients, improve the patient's experience, and potentially reduce the cost for this care that we provide. So we have focused on that model rather than on Medicaid per se.
Okay, so the idea would be to create a system that works well for everyone rather than sort of setting up a series of alternate delivery systems based on the payment model that, that folks receive their medical care through.
Yes, and we have looked at the Medicaid, we have looked at the Medicaid Medicare, we've looked at different payment models to see where we can be most effective in the delivery system. That decision is evolving as we speak. I don't think we have clarity as to the expectations that we are asked to deliver at this point.
Evolving as we speak could be a very good subtitle to this event. I think everybody in this room, though, is pretty aware that there's a lot of exciting things going on right now in Sacramento to implement this legislation. Major decisions that are being made about the structure of the insurance exchange and the high-risk pools and what Medi-Cal is going to look like going forward. So for those folks who aren't plugged into what's going on in Sacramento, it's not happening in 2014, it's happening in 2010. So Tom, if I could turn to you on the coverage expansion. One of the ways in which healthcare reform was sold to folks was that, well, you know, there are all these people going into hospitals and doctors' offices who are completely uninsured, have no source of financing for their care, and these costs are being shifted onto other people, and that's increasing the cost of their care. Well, if we just do this federal health care reform, it's a win-win situation because folks are going to have more money associated with them, and other people will see their cost growth slower than they would have. How is that actually going to play out in terms of folks coming into your hospital in the next 5 to 10 years?
Well, I think the short answer is consistent with the theme I think we've heard so far. It's really, on a certain level, it's too soon to tell. That's the short answer. From a conceptual standpoint, I think there is the potential for that to occur, but like everything else associated with the legislation, whether that occurs really depends on how a number of the provisions that are in the legislation ultimately get implemented. In our case at Cedars-Sinai, although many people may not know it, we're actually one of the largest Medi-Cal providers in the state of California, and tend to provide a substantial amount of the more costly care that Medi-Cal recipients need, given the nature of the institution and what it is we do. Over 30% of our Medicare patients are Medi-Medis, so people who are dual eligible. The law basically provides, two principal vehicles for expanded access, as we know, expansion of Medicaid and the establishment of the exchanges. The extent to which patients under those two initiatives would be able to access Cedars-Sinai will depend on exactly how that plays out, neither of which we have control over the processes that will establish them. So what decisions the state makes with regard to the Medicaid program and how it functions will determine whether or not those patients will continue coming to Cedars-Sinai. We're certainly hopeful that they will. And the same with the exchanges and the new health plans that are developed through the exchange mechanism. And until those regulations, I think, are more clearly defined, it would be hard for us to say. Post that period, I would say one thing. I think all of us tend to, there's a tendency, I think, understandably, to look for kind of single big solutions. And I think when it comes to healthcare, there's no one big solution. And also things tend to happen a little more slowly than are anticipated. So one issue that's been talked about in that regard is hospital emergency departments, whether it's ours or others. I think that you're going to see for some time still, after expanded coverage is offered, I think the issue of overcrowding in emergency departments will still be with us. And I think some of the evidence from Massachusetts and other places would reinforce that. It takes a while for both patients as well as providers. On the provider side, it takes a while for the providers to be able to change their delivery systems to be organized to provide that care outside of that setting, and it takes a while for patients to change their behavior and their expectations as well.
Sure, I want to follow up on something real quickly, because again, this is part of a conversation we've been having about healthcare reform for a few years now, that we were again told, well, the reason why people go to emergency rooms is because they don't have health insurance. But what some of the evidence shows is that, you know, people continue to go to emergency rooms. In fact, quite a number of people go to emergency rooms if they do have health insurance. And you talked about what the decisions the state making and what they're going to do. Do you have anything sort of, specifically that the state should be thinking about if they want to make sure that people still have access to emergency rooms and facilities such as yours going forward?
Well, at a certain level, the biggest thing that would allow for that to continue to occur is, of course, to make sure that the design of the Medicaid program is such that Cedars-Sinai can continue to be a participant in it the way we have and the way we would like to continue being a participant in it. If the system is set up in a way that channels patients in certain directions for certain purposes, that may no longer be the case. And so that's one of the things that we would like to make sure gets done in the right way, so that, again, the people who need the services that we can and are providing can continue to do that.
Okay, just for those who might not completely understand, what do you mean when you say channel people in a certain way for a certain purpose?
Well, I think people, it's a fairly sophisticated audience. I think people know that Medicaid is organized in a variety of different ways around the state. And so there are patients who are part of organized managed care systems. There are patients who are in what has been traditional fee-for-service. And the question is whether exactly what kind of payment models are set up, and then what mechanisms are used to see how those patients are put into one or another kind of delivery system. And again, from our standpoint, being a part of that is an important one, but that's what, again, we also don't control, we don't make those rules.
All right, absolutely. Well, turning back to Castle, I wanted to follow up on something that you said. So it sounds like you feel as if federal health care reform is a step in the right direction, and this coverage expansion will certainly help many people who now cannot access medical care. But in some ways, we may have just, with this coverage expansion, put what you might call a down payment on federal health care reform, and not all the businesses is done. What will specifically be necessary to make sure that everybody in California has access to clinics? Is it a question of more funding? Is it a question of a different structure of the coverage expansion? How exactly do we see that happen?
Well, just if I may piggyback on the question you just asked, Tom, and let me respond by suggesting that one of the ways in structuring the Medicaid system, the Medi-Cal system in the state of California, the payer system, the issue of the uses of emergency services, in fact, is some cases because there is no coverage, and many times it's just a heck of a lot more convenient to use an emergency service department rather than to visit a primary care physician. We need to change that attitude, that behavior. It's tied to the payer systems that we have in the state of California. We ought to redirect those resources and invest in building infrastructure and capacity at the community level. And I would strongly suggest to you the federally qualified community health centers and community health centers in general may be a worthwhile investment. That certainly appears to be the case from the federal standpoint. With an $11 billion investment at this point to build that capacity, it is my hope that that capacity that we would be able, that we could take advantage of those dollars that come in via federal legislation, and that begins immediately. So I hope that we can build that. Let me just point out Orange County, for example. The comment was made that there are sufficient primary care physicians in Orange County. I would challenge that statement, given the fact that we work in the Orange County community, I know that there are a substantial number of people that do not have access to primary care physicians. There may be the numbers there, but for some reason or another, those people in greatest need do not have access to primary care services and missed the historical opportunity, even under the Bush administration, to build federally qualified community health centers. There has been one federally qualified community health center in Orange County for the last 15, 20 years, at the time that Los Angeles grew substantially during that period of time and built a number of federally qualified community health centers. What do we need to do in the course of the next several years to strengthen what we have? Like every good practice in every good community, we need the infrastructure to be able to compete. Compete on price and compete on quality and compete on access. It means building our communication systems, it's building our information technology system, building our structures, having the right people providing services to the populations that have valuable bicultural capabilities. When you work with community clinics and you work with poor people in California, you must have those capacities within your organization to be able to survive. Interestingly enough, I did an interview just the other day with a publication. It's a business-focused publication. And they talked about community health centers being the emerging market. I found that a little interesting because I guess we've been a little dangerous. The emerging market. I said, what the heck is that? It's a foreign concept to us as a nonprofit that work and are driven by missions. The truth of it is, community health centers in the last 30, 40 years have evolved to being major providers of care in communities of need. There is not one community, one congressional district in the United States that does not have a system of community health care providers. We're here to stay, and it is projected at this point that in the next 5 years, community health centers will continue to grow. Today we see about 20 million people through community health centers. It is my hope that in the next 5 years, and certainly that's the intent of the legislation, that we'll add another 20 million people in the next 5 years for a total of 40 million people that would be seen through community health centers. Infrastructure, I have to say one last thing here. While access has been probably the most important issue that we have had the last 33 years that ultimate health services, today our focus is less on access and more eliminating disparities. Because as we all know, in every community, and in every provider system, that there are differences in outcomes because of where people live and their ethnic or racial identity. We need to be able to close those gaps. In order to do that, we need the infrastructure, the capacity within our organizations to be able to meet the demands both from the standpoint of efficiency and as well as from cost.
Excellent. I think it's important to make the case for these huge infrastructure investments that are occurring in community clinics. And this is one of the pieces of federal healthcare reform that's happening right now. And one of the pieces of federal healthcare reform that wasn't a huge part of the conversation last year. So that's one of the things that we wanted to bring to the fore. I want to turn now to the quality of care provisions in federal healthcare reform. And Dr. Chin, my colleague Leaf mentioned these provisions as a series of nudges to get folks to deliver care in a slightly different way, to pay them in a slightly different way. The question is, do doctors like being nudged? And are these sort of incremental provisions to try to get folks to reorganize the way that they deliver medicine actually going to work? How do we get them to work through federal healthcare reform if we really want to get the doctors on board?
Before I answer that question, I'd like to continue the answer here. I think we have to go back to what you had asked, stated. What is the vision for healthcare reform? It is to achieve the highest quality care at the lowest cost. Sometimes it may be in the CPO. Sometimes in your community clinic. More often than not, you'll be in the PCP's office. So we have to understand that there are multiple venues to achieve that goal. And we have to look at the community's needs and identify that specific intervention to achieve that goal. But we forget sight of the goal. The highest quality care, the lowest cost. then we will see different stakeholders with their respective self-interests come in and take that goal. So I just want to make sure that we have a common definition of what we're trying to achieve. The highest quality care, the lowest cost. This is what Elliot Fisher said, who runs DARPA, talked about when he spoke at our association's meeting. But in answer to your question about quality, the answer is the physicians will embrace quality. It is, you know, I don't want to say never, but I mean, all physicians want to do good quality. It is sometimes that barriers are set in that slows them down. And when there's a conflict between slowing down and calling a patient to get the mammogram done or getting to take their medication, it's a whole lot easier to see that extra patient than it is to make the outbound call. So I think what we want to do as we look to improve quality is we have to look at the processes that we have to provide quality and look at interventions that don't slow the doc down. If anything, to make it speed up. So I think that it can be achieved, and I think it was Victor Fuchs who said the 3 I's. You have to have information, you have to have infrastructure, and you have to have incentive. And it's probably in that order. If you put the incentive before the information and infrastructure, it ain't gonna happen. So I think there's no doubt in my mind that there's physician embracement quality. We see a lot of stuff now from IHA, right? They talk about safe, effective care, being timely, being patient-centered. All this has been talked about. Really, the time out is how are we going to implement this? Move it from a concept, move it from a philosophy, and get it out. It's just like when you took your baby home. What is it they got to do today? I think there's enough information, enough ideas that we have that we actually can make a change to improve not only the technical quality, but also the service quality for the patients.
Yeah, it sounds like what you're saying is that perhaps instead of putting a bunch of different regulations and structures on top of the work that the doctors are doing in their offices, you just need to provide them with the resources that they need, information and incentives, and they will provide the highest quality care. And what we don't want to do is be putting barriers up in front of these doctors as they serve their patients. What are you hearing from your docs? Do they feel as if the federal health care reform is going to make their jobs easier or more difficult? And going forward, how do we have to implement this to make sure that it does improve quality?
I think most of the individual physicians, individual offices, really don't think too much about healthcare reform and probably don't translate what the bill means to their individual practices. But as an organization, if you take what you just said and add to what you said earlier about 2% of our American school graduates going to primary care, what's going to happen with the shortage of PCPs? What's going to happen with the aging population, more chronic diseases? What's going to happen? So I think that what we have to do is begin to look at ways to truly transform the way we deliver care. So instead of the doc handling a social issue, handling an education issue, maybe we have specialists in social work dealing with social issues, educators dealing with education issues, nurses dealing with nursing issues, and the doc focused on those things that require only the physician himself or herself. I think by changing that model, then that's going to be a hard sell. Right. By changing that model, I believe that we're going to be going in the right direction.
Yeah, I want to drill down to this and bring in the other panelists, because this is an issue that keeps coming up again and again. Access to enough medical providers, access to the correct type of medical providers at the right times in the right facilities. So if you wanted to talk about some of the provisions that my colleague mentioned that are in the federal health care reform that are designed to increase the supply of primary physicians, that could be a hook. But I wanted to turn to you, Pastor and Tom, to talk about what do we need to do? Does federal health care reform do enough to provide the personnel that California needs and restructure the personnel so that the right people are delivering the right care at the right time?
Let me just briefly comment on two aspects of that. As I mentioned a minute ago, there's a little bit over $1.5 billion that will be made available through the National Health Service Corps, hopefully to train and set up residency programs and to train physicians who are interested in the area of primary healthcare services or services in underserved communities. That's the goal, at least the way we do it through the National Association of Community Health Centers. There is clearly another layer there that's terribly important to us. A lot more that has to be done is around nursing units, particularly as we see people living longer and longer and dealing with chronic conditions. At Ultimate, half of the business that we manage beyond primary healthcare services is long-term care, community-based long-term care. We know the demands that exist in managing people that are living with chronic conditions. There's no person more important in that than that nurse that's engaged on a daily basis with those patients that we're dealing with. To keep them out of institutionalized care, there are alternative systems of care. In healthcare reform, one of the areas that I thought would be terribly important to address, because there is no mention of that. We operate what are known as adult day healthcare centers, and a number of them throughout Los Angeles as well as in the Orange County area. Those adult day healthcare centers have done phenomenal work in maintaining people independent and in the community that are living with serious chronic conditions that would be otherwise institutionalized in skilled nursing facilities. Somewhere in the neighborhood between 36 to 40% of the people that we're seeing through those centers would be in skilled nursing, but for those adult day healthcare centers. And I think that this is terribly important, and it has to be included on a going-forward basis on any kind of healthcare reform at the national level, where Medicaid and Medicare would have access for payments and reimbursement for those centers. The reason I mention this is because on the one hand, where we're talking about building a system for the future, we have a governor at this point who is eliminating adult day healthcare centers in the state of California. It doesn't make any sense. 39,000 people would be put out in the streets if the governor gets his way. 40% of those would be institutionalized within the first year, and dismantling the system that has taken years to build and ought to be built for future services to people who are in need of community-based services.
Right. I mean, you raise an extremely important point. There are all sorts of cutbacks, apparently, air conditioning and chairs. We now see a situation where the federal, it's sort of one step forward, two steps back, where there's this federal healthcare reform process, but then Leaf and I work a couple of blocks from the state capitol in Sacramento, and you may have heard the weather's pretty clear up there, but there's actually a black storm cloud hovering right over our offices in the Capitol building, because whatever it is that you think about the state budget process, you're not happy about. And figuring out what's going to happen with the in-home supportive services programs in California adult day health centers and so on is a vital part of this. But Tom, I want to turn to you on this issue of the primary care physicians, and do we actually have the personnel to provide the care that people need when they come into Cedars-Sinai? Are you folks struggling to find the docs that you need?
So I guess a couple thoughts about it. One is in terms of the supply of personnel, the most acute shortages for us right now continue to be the areas that I think affect many institutions, and that is nursing and all the other allied health professions, which despite investments of several $1 million on our part and others to expand those training programs, the demand is certainly going to continue to outstrip the supply. We're in this interesting period right now where the shortage of nurses is perceived to have gone away because of the broader economic condition. And I think the worst thing that could be done is for people actually to come to believe that, because whatever's occurred now is transient by definition. And so to that end, for example, we continue to offer a significant nurse residency program to keep the pipeline of nurses coming through the institution. I know other organizations are doing the same thing. More broadly, with regard to graduate medical education physicians, we operate one of the largest graduate medical education programs in the country, so that issue is one of great interest to us. I think the health reform legislation took a good step forward in terms of expanding the number of funded residency slots, in terms of allowing some historically unused slots now to be used, but it still falls short of having enough physicians. Even there's a debate in the education community about whether there are enough physicians and we can just solve the problem with advanced nurse practitioners and other individuals of that type. I think that has to be part of the solution too, but it's pretty clear that the need for primary care physicians will continue to grow. And when it comes to primary care physicians specifically, that is the greatest challenge I think we and every other organization continues to have.
Sure, and then Tom, let me start with you. I want to turn to the sort of third piece of this before we open it up to the audience, which is the issue of value in medical spending, the issue of cost control, the steps that the federal government took through federal health care reform. This was how it was sold, right? We heard about the soaring growth of medical care in this country, how it was affecting individuals, affecting businesses, premiums for small businesses in particular skyrocketing. And I was challenged. I gave a talk about federal health care reform in Colorado. And I was talking about the need to control health care costs through federal health care reform. And a businessman came up to me, a very nice guy, and he said, Micah, explain this to me. You're telling me that the problem is that we spend too much on healthcare, and the solution to this problem is to spend more on healthcare. That's counterintuitive, and maybe it's counterintuitive because it's wrong, and he really wasn't sort of putting this forth as kind of an argumentative position, but what we really need to explain is how is spending, roughly, we don't know exactly how much, but $1 trillion more on healthcare going to help control healthcare costs in the United States? Are these initiatives, such as reducing hospital admissions, readmissions, going to actually get us there? And will we see this cost trajectory bend coming out of healthcare reform?
So I think the answer to the question of whether health reform will impact cost or not depends on where you sit. As part of the health reform legislation, for example, the American Hospital Association committed to $155 billion worth of less payment under the Medicare program over the next 10 years compared to what had been planned. So in terms of the federal government looking at the unit payment question, how many, the price being paid by Medicare, there's no doubt on both the physician and the hospital side that's going to be less than it would otherwise occur. And one thing we can be sure of is both at the federal level and at the state level, ultimately within the politics of what amount of money our society is willing to spend, if there's anyone who will control how much is going to be spent, it's going to happen at the governmental level, as it does today. However, there's a corollary to that, and that is commercial insurance. And I think most times when people talk about the cost of health care, they're talking about the cost of commercial health insurance. In that regard, a couple of things. I do think the payment reforms that are in the bill are a good start. And I do think they provide an excellent framework to be able to deal with one of the two major components of the cost of health care. The cost is a function of price, and it's a function of demand. And the payment reforms, I think, are a mechanism to moderate the demand or the utilization, better said, the utilization side of health care. With regard to the price question on the commercial side, that's going to be dependent on two things. One, what can we do to get better control on the input costs on the delivery side? So people ask the question, why are hospital costs going up so much? Well, 60% of the operating costs of a hospital are people. Because of the shortages in healthcare professionals, salaries for everyone who works in healthcare has been going up probably 2 to 3 times the rate of general inflation. If that question doesn't get addressed in some way, it will be very difficult to get a real handle on the cost. The other major component, however, of the cost of healthcare from a commercial insurance standpoint is the government cost shift question. Some of that will go away to the extent that doctors and hospitals are able to operate more efficiently so that their losses under Medicare and Medicaid, which are now substantial, go down. But in the end, and I think this is one of the remaining questions that are out there, is getting better parity between what government program payments might be as well as and commercial insurance, because the cost shift question remains, estimates have been made 10 to 15% premium in California associated with caution. 80%, Medicare pays about 80% for folks' information on the hospital side of what it costs. Medicaid, depending on the institution, may pay anywhere from 30% of what it costs to as much as in a good situation, probably 60% of the cost. That's not an insubstantial amount of money and is a big part of the cost of commercial health insurance.
Sure.
Before I do that, the reason there's nothing in the healthcare legislation about how to improve quality is that nobody knows how.
So there's nothing in the federal healthcare legislation we know will improve quality because we don't know how to do it?
You have multiple people who believe certain things will improve it, but there are very few models in this country that are hitting all 8 cylinders. That's all I'm saying. I mean, so I think in some ways it's a blessing in disguise.
Okay.
Let me go back to the cost piece. So even when the social scientists look at the overall cost of healthcare in this country, and they look at it in terms of the healthcare premium, even if you add the additional costs for making sure that patients get their colon cancer screening, make sure that they can get the medications for their diseases, et cetera, there's still a lot of waste in the system. And the waste has been defined in the areas of certain imaging, identified in certain procedures, perhaps back surgery, perhaps stents, perhaps hysterectomies, perhaps a number of different things. A lot of testing, in some ways, are not felt to be appropriate medically. Now the patient may say, I want a total body scan. A total body scan. But is that truly a medically necessary procedure? Does the evidence-based medicine support that order? So when you look at that concept, evidence-based ordering, evidence-based testing, then when you look at that, you will see that there is a lot of waste in the system. And the social scientists have said that if you eliminate the waste, add back the cost to improve chronic care, that you could potentially reduce 1/3 of the healthcare premium. So this doesn't address what Tom was talking about at the hospital level, but I think from the social science level, looking at aggregate costs in this country, this is a way that we potentially reduce costs. And I remember Elliot Fisher, the guy who runs Darwin, said he wants to go out and create these non-proliferation treaties. Okay? How many MRI scanners do we need in LA County? How many Da Vinci robotic surgery units do we need in this country, in the city of LA, the county of LA? For every one that you don't need, all you're doing is adding costs to the system without creating value, without improving the quality for our patients. So, I mean, when you look at that, then this is the way that we need to look at how to improve quality and reduce costs for the country.
I want to cast a little, pick up on this whenever you like, but I think that Dr. Chin posed, well, a pretty controversial, perspective here, that we don't really know how to deliver high quality at a low cost. And a lot of your remarks, I think, are premised on the idea that community clinics in particular deliver very high quality medical care at a reasonable cost. So do you think that federal health care reform does enough to support that?
Well, I think that number one, as organizations like AltaMed and federally qualified community health centers across the nation have had a fundamental commitment, mission-driven organizations, a fundamental commitment to provide access and to provide access to populations in greatest need at the lowest cost possible. That has been pretty much what has driven federally qualified community health centers throughout the United States. That has not dramatically changed in the 33 years that I've been involved with AltaMed Health Services. In fact, has not changed, other than to focus more and more around disparities. So what are the things that we need to do over the course of the next several years to reduce costs and to provide the sort of services that ultimately improve the outcomes to our patients? The industry is full of examples. While now no one in particular has developed that one 8-cylinder machine in the community, there are many, many systems in play that empirically have been proven to help reduce the cost and to provide better outcomes. It is those things that I, as the President and CEO of a federally qualified community health center, are totally committed to. Where there are systems that have been open to populations that have had a way to pay for it, either through commercial product or through some other product, there are many populations, significant portions of population that have not had traditional access to systems that look at outcomes, that do the sort of measurements that you were talking about, Dr. Chin, that are essential in cases and are managed in such a way that we are conscious of the cost that we have to with federally qualified community health centers, working with populations that normally do not have access and do not have the payer systems to do that. There are models, for example, medical homes. It's talked about patient-centered, there are 7 principles, and all of you are familiar with those principles on it. In order to get to that stage, coordinated care delivery system, there's huge costs associated with it. You have to be able to build the capacity. Equally as important to me and my perspective is the duplication of efforts that exist in any one community. A small community like East Los Angeles, for example, the players in that community, be public hospitals, private hospitals, nonprofit institutions, medical groups, the duplication that exists in that community and the waste of resources by not having a common platform to speak with one another and manage the care of people in need is an enormous amount of dollars that are wasted in that system. So I just sense that there's a lot more that still has to be done. The bigger picture, I think the 2 gentlemen are on target. There are areas that we need to refocus our efforts at this point.
I love that from the perspective of best practices from California's experience, and will it actually support those organizations that are doing this work?
Well, I think to the extent that the different payment models that are described in the legislation or talked about around the legislation, so long as those are implemented the correct way, then I think there is hope to achieve the kind of goals that we're talking about on both the quality and the cost side. Again, there's quite a distance, as I say, between the lip and the cup, and we have to make sure that when these things get implemented, they're done in the right way. There is another aspect of the legislation that I think is also can also be a positive contributor if, again, done the right way, and that's the piece of the legislation that deals with the question of comparative effectiveness. So to Bill's point earlier, you know, there's a fair amount of medicine today for which there is good evidence, and the question there is how do you speed the adoption of that in a more uniform way? And I think the payment system will be a turbocharger for that, again, depending how fast it gets developed. Then beyond that, there still remains, frankly, a substantial amount of medicine for which there remains a great debate. And so the question will be, and to say nothing of discoveries yet to come. So whether take the area of stem cell treatment just as one bucket of new medicine that's going to emerge, is emerging now and will emerge over the next decade even more. Coming up with, you know, the analysis of the effectiveness of that versus other treatments, et cetera, et cetera. This is only going to get more complex because of the increasing complexity that medicine and the direction medicine is taking. So getting on with the question of comparative effectiveness in some more orderly way, I think, is an important part of the public debate that then has to take part around about that and other aspects of the system.
Great. At this point, I'd like to open up the conversation to the rest of everybody here. And out of respect for the panelists, I would ask that you phrase whatever you have to say as a relatively concise question. If folks want to begin generating those ideas, Leif, I wanted to turn to you based on your sort of overview and what we've heard so far to see if you wanted to open up the program with a question.
Well, I was struck by what Tom just said, and I had to mention that earlier, but I think the comparative effectiveness, the evidence-based medicine, all of those get a bit of a boost through federal legislation. And, you know, I'm not now and probably never will be under federal confirmation, so I think I can say that every other country in the world tends to be much further down that path and have instituted institutions that are, really deal with the cost-benefit analysis of medicine and not simply the first stage of comparative effectiveness. So in the stimulus bill and then subsequently in federal legislation, the movement in that direction is very, very welcome. And obviously welcome any questions that deal with that or anything else we talked about either in the coverage or delivery side.
Sure, and if folks want to ask questions, I believe we have a microphone here up front.
And just identify yourself, please.
I'm Anson Lee from Korean Research Center. Thank you for attending panelists and especially you, the moderator. Great. I want to ask you, all of you, simple, straightforward, common sense question. And I want to hear a straight, simple, common sense answer. Okay? So today's, if I may take a 1 minute, affordable health care. To me, it's a nonsense. What is affordable health care? The medicine is a holy profession to cure people, help people. And it says affordable. Whatever, if you cannot afford it, I'm not going to cure you. That's what's happening, right? So now, if I take one example quickly, I visited my home country, Korea, 15 years ago. I visited my father's youngest sister, visited her, and she said, "Oh, my son is over 28. He's in the hospital. He went to the total hip replacement hip surgery, and he has to go to the knee surgery by a motorcycle accident." I was so shocked. How can I pay? So I went to visit him. He said, "How are you doing?" He said, "How can I pay?" So don't worry about it. That was 15 years ago. When somebody has a job, the employer covers the health care. If they need help, government helps. If they lose job, if they need no job or children or whatever, they are covered by government. At that time, 15 years ago, Korea is a poor country. But because they went through the Korean War, so the misery of the people, they took initiative, covered every people in Korea at that time. Now, this is affordable care. United States is the richest country in the world, and they said that we cannot afford health care for everybody. Right. To me, this is a nonsense. Come on. Yeah. This is a health care reform. Well, we need a health care revolution. Right. To help all people in the United States.
Yeah,
we can afford it.
Yeah, I think it's an important question, and just because that was the task force that we ran, when we're saying affordable care, what we're trying to do here is deliver absolutely whatever care that people need, and do that in the most efficient and affordable way possible. So that's what we're talking about. Not sort of we're going to make affordability the first criteria, and well, if not affordable, then tough luck. Because I'm a social scientist, I guess I should come out about that right now. And I believe those social science studies that I've read, that a third of healthcare spending is unnecessary. So that ends up roughly, $800 million, right? Or I'm sorry, no, $800 billion. Once we deal with those $800 billion, then we can worry about whether or not we're providing people with all the care they need. But I want to open that up to the panelists if they have anything to say about that.
I don't think I have a lot more than what Mike had just indicated. I think the purpose of the report and what we're trying to articulate is healthcare that Americans expect. And there is, I think, every country and every culture has its own expectations in that regard. So I think that's the backdrop. And then the question is, what is affordable, both at an individual level as well as at a societal level? And I think the concern about cost and affordability is both an individual, but in an increasingly global economic world, the question of the relative cost in the United States compared to other countries has become a focus of attention as well.
Any of the panelists want to weigh in on that one? All right.
Hi, my name is Mike Russo with CalPERG, and I think the panel's been great for laying out all the different pieces of reform and what that'll mean, but I think we all know there were a lot of reforms that either didn't make it into the federal bill or they're a much weaker form than they might otherwise have been in. And so I'm just curious what you think the biggest single missing piece or further reform that's needed. And just wanted to make it not another 30-minute question.
Great. Thank you, Mike. What's the unfinished business of healthcare reform, folks? What didn't make it in there?
Well, I could have seen a lot more about comparative effectiveness, but to take another thing that's not in there, there's nothing in federal reform, and maybe there shouldn't be, about scope and practice issues and many of the things that many of the folks in the panel are talking about that are going to be pretty critical in California going ahead.
I mentioned already what I think is an area of great concern to me is around senior care, availability of adult day health care and community-based services for people living with chronic conditions.
I think that comparative effectiveness, evidence-based medicine is big. It's also very, very hard. And the important thing that I would like to convey to the audience is what's good for the doc has got to be good for everybody else. So the state's got to agree that the decision made by evidence-based medicine stands. The employer has to agree that it stands. The jury, the courts have got to agree that it stands. Because these guys don't stick to it. Evidence-based medicine is dead. I simply remind you of the case of the bone marrow transplant. That Health Net lost millions of dollars. No evidence at all. Court said, provided. Penalized Health Net, many millions of dollars. So, good idea, evidence-based medicine, but it's got to apply to all stakeholders.
All right, sir.
Good morning, I'm Aaron Najarian. I'm the senior partner of the team of consultants. We're a social-based marketing firm. I wanted to just bring up something. The evidence base, I think, is a big issue. It's hard for people to remember, but in the 1980s, Latinos were considered the healthiest population. They were younger, and so a lot of the chronic conditions they're also underdiagnosed. And so now we see a diabetes epidemic. We're seeing now the fastest growing, fastest aging population, the seniors, we're seeing they're underdiagnosed in osteoporosis. So if we're looking at evidence-based, where does the evidence start compared to trends? Because I would say that it was a bit of a challenge in the 1980s to say, oh, there's going to be an epidemic of diabetes among Latinos. And I don't necessarily see that we're looking ahead on things like osteoporosis, and that's going to be our largest group. But there's many, many chronic conditions, and maybe not the evidence there right now.
Well, for a number of chronic conditions, fortunately, there is some evidence where the challenge comes in is when people have multiple chronic conditions at the same time. Then it does get a little more complex, as Bill was referring to. But again, I think that the reform legislation does put in place a good framework that provides an incentive for doctors and hospitals and others involved in the care to do what you just said. To look ahead, to consider ahead based on the individual's genetic background, their overall socioeconomic status, all the factors that ultimately factor into health. So again, if we execute correctly on the framework that's been put in place, I think it puts us in a reasonably good position, certainly much better than the current system to deal with the kind of issues that you've raised.
And the other dyad to this is the patient. So you tell the patient, stop smoking, exercise, eat right, etc. They have to embrace that philosophy. If they don't, whose failure is it? Is it mine? Is it the patient's? Is it society's? I don't know the answer. But until the self-management question is answered, I think we're going to always have the issues that you brought up.
And I would just add to this that the truth of the matter is that issues around disparities have been with us for many, many years. It's the reality in our society. It's true in California as it is in Maine. And as long as our institutions are what they are, those kind of issues will persist. We have marvelous opportunities through healthcare reform, not only to bring the resources to provide greater access, but to build infrastructure capacity and to bring to the table those individuals that are focused on eliminating those disparities and will look and invest resources to to ultimately eliminate them. Key thing, information technology. There are a number of approaches, accountable healthcare organizations, medical homes, and other ways that are much more specific. The use of evidence-based quality assessments and outcomes, and hopefully will get us way ahead of the curve on issues that may be important to underserved communities.
Thank you.
Hi, my name is Elena Ong, and I'm an advisor to the Asian Pacific American Medical Students Association, and I also was very active in getting health reform passed with the American Medical Women's Association. I'm really pleased that today, 50% of medical students are women, and about 20-some% are Asian American Pacific Islander. And I think we have a great opportunity to actually transform health management into wealth management, and I mean W-E-L-L-T-H. And that said, one of the things that my cohort is particularly interested in and very much embracing is this consumer partnership and focusing on prevention and wellness and focusing on cultural sensitivity. And so I want to kind of throw the question to Castro because truly admire yours in terms of where we're going with this, not just the medical component, but also telemedicine in rural areas. And let me just say one other thing. One of the, I work with the students a great deal in terms of listening to the White House conference calls and honoring or celebrating the fact that 26-year-olds are going to be covered. And I just said, well, we have one challenge there. Because if those 26-year-olds are Asian, Latino, perhaps African American, or their parents work for small businesses, they have a higher chance of being uninsured. So even with that incredible opportunity, my job actually is to educate small business owners that get a 35% tax credit. My job is to convince the IRS to translate those forms in Asian languages and even into it, TurboTax. So kind of looking at that model and so from a consumer point of view as well as from a medical view.
As the federally qualified community health centers, one of among many things that distinguish the organization, we are after our federally qualified community health center, is that 51% of our board of directors have to be consumers, actual users of services. A revolutionary thought that you have 4 people that are managing your organization, and my bosses in this case. That among many other things have really made, I think, community health centers particularly responsive to community needs. As we look at the future, I think that our organization and our organizations across the United States have to be a great deal more competitive. Competitive from the standpoint of access, quality, and efficiency in terms of how we manage our operations. And ultimately, it's all about outcomes and what we're able to deliver to our patients. None of that is possible without having the personnel that is the doctors, the nurses, the physical therapists, the occupational therapists, and those individuals that are committed to the populations that we are presently servicing. And quite frankly, that are committed to innovation and looking at ways of improving a service delivery system that has a track record of success. The model works. After 40 years, Ted Kennedy introduced this concept in the Senate bill 40 years ago. That system with a couple of centers, one in Massachusetts, the second one in Mississippi, that now today represents an extensive service delivery system. We are excited about partnering up with family practice, with residency programs, be it pediatric residencies that we manage, the outpatient clinic at Children's Hospital today. Take a great deal of pride that 80-some residents are rotated through that particular practice. And we are extremely interested in looking at partnerships, other federally qualified community health centers with residency programs, pediatric, OBGYN, internal medicine, and those kind of practitioners that have an interest in serving our communities. Thank you for your question.
You said this was co-sponsored 40 years ago by a senator from Massachusetts and a senator from Mississippi, which makes me wonder whether that was the last time that a senator from Massachusetts and Mississippi co-sponsored.
No, I'm sorry, my apologies. Senator Kennedy,
yeah.
And Adam Clayton Powell, to be honest, partnered with him on the House side.
Oh, okay.
But they opened up 3 centers. One was in Mississippi, the second one, of course, had to be in Massachusetts.
Oh,
and the third one had to be in Harlem.
Okay. All right.
Good morning. My name is Lisa Sugarman. I'm the Director of Policy for the SCAN Foundation in Long Beach, California. One of the parts, what I consider to be a pretty significant part of healthcare reform that wasn't discussed today is really around long-term care. I mean, it was highlighted in your comments about adult day healthcare. There is some reference to needing allied professionals to be supporting doctors in integrating services both on the medical side as well as on the social service side. There are a lot of questions I could ask around this, but I think I'll focus maybe on health professions and needing more of these health professionals involved, growing this health professional population that is needed for an aging population that is, we're just going to see the tip of the iceberg in the next year. We're only going to see the growth of the aging population over the next 20, 30 years. So I'm curious from all of your perspectives, do we need to change the way that we train professionals, not just physicians, but nurses and other allied professionals? And then how do we get them all to work together? So Dr. Chin, you talked about having social workers there to provide support. I think there's two things there. One is definitely needing that support for helping people locate services in the community that will help them stay in their homes, in the communities where they prefer to be. But also, how do we get physicians to be able to recognize that there are needs and connect them with those services? So I thought I'd just open that up to you guys and see what your thoughts are about that.
Yeah, I think that's an excellent question. Since federal healthcare reform wasn't sort of a magic wand that fixed everybody's problems, and it took us about 100 years to get around to doing it even in the state that we did, do we have the political will, do we have the literal willpower to deal with the major issues that federal healthcare reform only really got us started on? And one of the huge ones is the long-term care needs.
Well, I think the question was beyond long-term care to also just coordination of care in general, and that's something we haven't talked about as a quality issue. Just a personal anecdote. In the last 3 years, I lost my mother and my mother-in-law, and I like to think I know the system and how to make the system work. It drove home to me as the way a friend of mine describes it. He says, if you're elderly in America and you need health care, if you don't have a daughter, get one. There's a lot of truth to that. Now, in truth, no system is going to kind of provide the kind of support that families can and ultimately must. But we can do a much better job. And you put your finger on, I think, one of the next great challenges, and that is restructuring the educational system and doing it in a more integrated way with the delivery system itself. So not so much a separation between the educational system and the delivery system. And there's a whole lot of things underneath that theme. But if I had a theme about changing the education system, it would be along those lines.
I love that line. You don't have a daughter, get one.
And you know, all these concepts need to be done. And I think that when you say like the Accountable Care Organization, looking at what the National Priorities Partnership talked about, being patient-family centered, being collaborative, having care coordination. Because within our own organization, I'm a bit crude sometimes when I say every time you have a handoff, you have a potential risk of a screw-up. Okay, so the more seamless we make the healthcare transition, the less likely are we to introduce unsafe intervention for the patient. But I think collaboration, coordination care is key. I think we are finding physicians who are interested in long-term care. Some of these have geriatrics in their background, some of these have different trainings, nurse practitioners, social workers, geriatric social workers. We are seeing this resource in the community today, as well as obviously community resources.
We have a long history of involvement at Altamed with long-term care, back to days where it was something that was not only if you had it as part of your mission, which back in 1981, 1982, where we founded the first adult day healthcare center. I could not agree with you more. There are a scarcity of individuals who are trained, whether they are physicians, mid-levels, nurses, care managers, physical therapists, occupational therapists. I'll sign them up right now on the spot if anyone in here is interested. They're very hard to come by. To get people who are bilingual and have bicultural capabilities is next to impossible to do. There's a whole heck of a lot more that has to be done. our educational institutions and universities, our training programs for residencies. There has to be a greater emphasis on long-term care. After all, and the change in terms of attitude, a huge change in attitude. Developing a medical home, an enhanced medical home, is not just simply a theory. It is a way of doing business, and it requires a fundamental change in your organization as how you deal with those individuals dealing with long-term care problems. It is a huge undertaking to build the infrastructure, the information systems that you need, the coordinated care that you need, the connections with the appropriate institutions in the community, and of course the engagement of that family. Those are hard enough, but to get a staff and to change the thinking of your organization is huge. We need to invest resources in training all staff that's involved in that, but particularly the professional staff.
All right, I'd like to get to the questions of everybody who's left in the line right here. We've got about 5 or 10 more minutes. So if I could get the folks who are in line to ask their questions in a concise manner, potentially address them to a specific panelist, and the panelists could answer them in a concise manner.
Should we do them all at once, Mike? Why don't we do
that tends to be a little messy. So let's just get through these as quickly as we can.
Hi, good morning. I'm Stephen Simon, I'm the AIDS coordinator for the City of Los Angeles. It's my job on behalf of the Mayor and Council to, one, reduce new HIV infections and ensure that people living with HIV and AIDS have access to quality care. That said, I first asked Costello, for an organization like Alton who has a history of testing, prevention, and care for high-risk populations with HIV, what aspects of healthcare reform do we need to see enacted in order to facilitate the expansion of those services? And I would ask Bill, your comments about evidence-based medicine suggest that large physician practices such as healthcare partners might be hesitant to enact the CDC guidance for routine expansion of HIV testing across the general population.
I think that the bill provides a marvelous opportunity. Healthcare reform provides an enormous opportunity to expand that service delivery within all federally qualified community health centers across the United States, all healthcare delivery systems in the United States. The training aspect of it and looking at ways of incorporating into the actual training at educational institutions, the need to do the appropriate screening and appropriate treatment of individuals living with HIV and AIDS, and incorporate them as to the funding streams of payer systems, both federal, state, as well as the for-profit and employer-sponsored systems. Those are the kinds of reforms that we still have to see. My hope is that in the course of, as we move towards and closer to 1214, that we may be able to approach those in a way that makes sense to our delivery systems.
All the guidelines have been rolled out to every doctor in the organization. I simply look at the data, the outcomes that are produced. And the only area where I see 95% success rate is in pediatric immunizations. And the reason that's the case, of course, is A, you got a mother thinking what's best for her child, and you have the school system that won't let the kid in unless they have immunization. So if you look at the other stuff, I jokingly have said, I can get every Medicare patient immunized with flu if I link that to their Social Security check, okay? So, you know.
There's not a policy proposal. But it would be effective.
It would be effective. But, you know, it's just trying how to weave that into the workflow of the typical doc to make it seamless.
All right. Yeah.
Yes, I'm quite concerned about the healthcare reform, the way it's been presented here. Just because, you know, I come from France and I know the system quite well. When you're talking about evidence-based, you know, in France, they calculate the cost. It's why we don't have $1 million baby. Because if an infant is born at 500 grams, we don't provide any care. But I think one of the issues we have here, and I have heard it around today, is to develop a medical team involving everybody the nurses, the physicians, the occupational therapists. And I don't see that kind of energy going around. There's over a lot of feud between, and I think that's what we have to put a tremendous emphasis, in it. And I must say, I have been in the U.S. a long time. And I must say, only recently I joined Healthcare Partner and had the best care I ever had.
Well, I think that comment pretty much speaks for itself, so let's move on to our next question.
That's what we deal with, because people are working against each other all the time. Last weekend, the Californians Association, measure a candidate really, that should never happen. We try to solve a problem, we should all do it together.
Yeah, and that was part of the goal behind our task force of bringing together people across a number of different areas. Ma'am.
Hi, my name is Marilyn Sherman. I'm the benefits manager for a local college, Lewis College of Art and Design. And when I'm listening to your expertise, I'm concerned at the consumer level how big of a task it's going to be to get them educated on what this actually means for them, because they hear affordable health care and they think that next year their premiums are going to go down. And we know for a fact that the premiums are estimated to be about $12,000 by the year within 5 or 6 years per individual. And do you have any resources that we can use as practitioners to kind of guide our various organizations on getting our employees and ourselves kind of geared up for the fact that it's going to continue to be expensive to get health care, regardless of the changes in the organization. Especially because now we're trying to get everybody some affordable health care.
Right, particularly if we don't take the steps such as, well, if you don't pass a certain threshold, we just don't provide any care to you. That's something that America's not comfortable with, as was very clearly demonstrated in some of the conversations at town hall meetings that happened a year ago that were far less sort of collegial and civil as this one so far. So we're going to have to deal with this in more complicated ways than really just cutting off people's care. But I want to open that up to the panelists. Tom?
I'm not sure this is particularly helpful, but most organizations are working with the benefits consultant of some type. And I think as far as alerting the organization to what's going on in the marketplace and helping to educate staff about alternatives, those are usually the kind of people that I'd like to suggest.
No, we definitely have those resources, but as a person in charge of the benefits, is there any websites or any kind of literature that you could provide for us to access?
The new government website, I believe it's HealthGov, is surprisingly good. Okay, it started a couple of weeks ago.
Yeah,
I'm losing track of time, but it's got a lot of genuinely useful information and genuinely workable worksheets and that I think we can talk a little more later. But that's one place
Healthcare.gov.
Healthcare.gov.
Ma'am?
Good morning. My name is Elizabeth Wilson, and I am a practitioner of the Escape Research Center. I'm also a Medicare advisor, and I would like to ask my question to Dr. Michelle. I have a population of people that are into wellness and prevention. With these federal tax dollars, is any of that money going to be allocated for health clinics that are community-based that provide other modalities than Western medicine?
The program does provide information, funding for wellness program. I have to fall back on the position that I made earlier, that if we look at comparative effectiveness and evidence-based medicine, we need to look at those other interventions and see how it compares in terms of outcomes being produced. I can't answer that yes or no right at this point without seeing the specific intervention and the outcomes associated with it.
Yeah, but I think the idea is that what we're hopefully moving towards is a world where evidence is taken more seriously in medicine. And so if there are interventions from any different modality that are really delivering quality outcomes at a reasonable cost, then we will have to turn to those because healthcare costs cannot go up forever. So thank you. Ma'am?
Good morning. My name is Sandy Bryant. And my question is more on the unemployed, the uninsured, and the COBRA payments. Since the government did not extend past May the COBRA discount, what is going to happen? Is there anything with the federal level that's going to happen with that of an unemployed who the insurance benefits not extended and they trying to do basic needs instead of insurance, food, and rent? My question is dealing with that. Any answer?
Yeah, absolutely. This is kind of, it's like, what do they say on the British subway, or the London subway system, mind the gap. So, last time I checked, it's 2010, and still is right. And a lot of these revisions don't come in place until 2014. So if I could sort of expand on your question a little bit, but I think this is at the heart of it. How do we get to 2014 given the people who need this medical care or insurance right now?
Well, I think in the near term, for the population that you described as well as others, I think that those individuals are going to continue to access hospital emergency departments, community clinics, hospital-based clinics, and other resources that exist today. And I think you put your finger on an important gap that it was not addressed in the legislation as this transition period was set up as part of the political process in order to get something passed at some point.
I know that at least the experience of community clinics across the state of California, including federally qualified community health centers, when the time of economic downturn is when we see spikes of significant increases of patients in our facilities that do not have and who have lost healthcare coverage as a result of the economic downturn. Most community clinics, and most I should say, community clinics across the state of California, many that are supported by hospital groups and supported by medical groups, continue to do fundraising and raise resources. I know it's not the correct what you want to hear, but those are the best options that we have in today's economy. It's accessing those organizations that have traditionally served the underserved population. Interesting enough, we have also seen spikes in Medi-Cal enrollment. We certainly have seen it in Orange County. We have seen it also in LA County. All along with that continues, not the best option, but it is an option that is available to people that have lost coverage as a result of the economy.
Thank you.
Did you want to make some wrapping up comments? Well, again, thank you so much for coming. I really thought it was a very civil conversation, but I thought also a very productive conversation. I was sort of wondering if we build it as an alternative town hall, if anybody would kind of take that as an opportunity to get all town hall on us. But I'm glad that you stayed here. And I'd like to, just for 1 minute, wrap up some of the things that I heard today. So if you could stick around for that. I essentially heard 3 things as priorities going forward, and that a lot of these things weren't dealt with by federal health care reform, may not be dealt with through federal health care reform, and therefore really may have to be dealt with more specifically here in California through our own legislative processes, our own organizations. And those 3 things are personnel flexibility. All of the different speakers up here talked about not only the need for more health professionals, but the need for the health professionals in the right places, helping the right people, empowered in the right ways, working within organizations that work for them, and expressed concern that federal health care reform may not have finished the job as it relates to personnel and personnel flexibility, and therefore that we need to seriously think about those issues within the California context. The second thing that kept coming up again and again is the unfinished business of healthcare reform that we have to think about going forward is evidence-based medicine, comparative effectiveness, getting the so-called waste out of the system, and we may have to think about how we do that in California more than the federal health care reform actually accomplished. And then the third thing is really the demographic trends. And so under this, I would put both sort of the health disparities and what's going to be happening in different communities, diverse communities here in California. Healthcare reform did some with putting more money towards community clinics, but it's actually going to take all the different organizations out there in the institutions, the hospitals and the physician practices, both the small and the larger multi-specialty practices, to deal both with the demographic trends related to the rise of obesity. Another thing that wasn't mentioned, but has been very big in the papers recently, is the rise in Alzheimer's, particularly with the increased diagnosis, and then just generally the issue of long-term care. So the question is, do we have the willpower to do this here in the state? Or is everybody going to want to kind of rest on their laurels and say, well, we did federal health care reform? I know that the folks in this room are. I know that the folks in this room, and I want to just thank all of you for the effort that you put into these issues every day. Thank you for coming to this panel and thinking about looking forward rather than looking back. How we make federal health care reform work in our hospitals and community clinics and doctors' offices and homes to make sure that we have more wellness and better, more affordable care delivered in our facilities. So I'd like everybody to thank the panelists that we had today. Really appreciate I'd like to thank again our sponsor, the Blue Shield of California Foundation, and our partners, the Integrated Healthcare Association and Pennington Media Group. And folks want to stick around and network and have some more food. We've got this room for a little longer. And thank you again for coming.